A 64-year-old man named Vincent came to me 23 months ago. He was a former construction site manager. Broad, physically capable, the kind of man who had spent 4 decades working in conditions that would have broken most people and had never once taken a sick day he could avoid. His wife had been trying to get him to see a cardiologist for 8 months. 8 months of conversations that went nowhere because Vincent felt fine. Not mostly. Fine. He was working in the garden. He was sleeping. He had no chest pain, no shortness of breath at rest, no dramatic symptoms that he could point to and say, "That is the thing. That concerns me." What he had was 5 things he had stopped mentioning, because each of them had a perfectly reasonable explanation and none of them felt like a reason to bother a cardiologist. He had been feeling more tired than usual for about a year. He had noticed that climbing the stairs to the bedroom left him slightly more breathless than it used to. He had been waking at 2 or 3 in the morning with an uncomfortable feeling he described as indigestion and packing. Antacids, that helped somewhat. His ankles had been slightly swollen by the end of most days for several months, and occasionally, not often, maybe once every 2 or 3 weeks, he felt a strange awareness of his own heartbeat. Not pain, just an awareness, a sense of it being there that he did not usually have. 5 things, each explained away. The fatigue was age and a busier schedule. The breathlessness was deconditioning after a quieter winter. The indigestion was the spicy food his wife kept telling him to stop eating. The ankle swelling was the heat and the amount of time he spent on his feet, and the heartbeat awareness was stress. When I reviewed Vincent's case, his echocardiogram showed an ejection fraction of 38%. A normal ejection fraction is above 55. His left ventricle was enlarged. His coronary angiogram showed significant disease. In 2 major vessels, he was in early heart failure that had been developing for at least 18 months. The 5 things he had not mentioned to a cardiologist were not separate minor inconveniences. They were a coordinated and specific communication from a heart that had been trying to be heard for the better part of 2 years. I'm Dr. Kevin Adual. I'm a cardiothoracic surgeon. I spent over 30 years operating on hearts, repairing arteries, and reading the language that the heart uses when it is under serious stress. What I'm about to share with you, most doctors won't bring up at your annual checkup, but after 60, it matters more than you think. There are 5 silent warning signs that the heart sends before a serious cardiac event, signs that are individually explainable, collectively unmistakable, and consistently dismissed in the kitchens and living rooms and GP waiting rooms of people who feel, by most reasonable measures, fine. Today I'm going to walk you through every one of them. I'm going to tell you what each sign means, why it gets explained away, exactly what is happening inside the heart when it occurs, and what you must do when you recognize it. Stay with me, because the 5th sign on this list is the one I encounter most frequently in the histories of patients who come to me after a cardiac event, sitting there, unrecognized, in the weeks and months before everything changed. Before I take you through the 5 signs, I need you to understand something about how the heart communicates distress that most people have never been clearly told, because this understanding is what transforms these 5 signs from 5 separate, minor complaints into a coherent and urgent message. Think of it this way. The heart is a pump. A remarkable, tireless pump that beats approximately 100,000 times every single day without rest, without pause, without a single moment of voluntary effort on your part. When that pump begins to struggle, when its muscle weakens, when its vessels narrow, when its electrical system becomes unreliable, it does not immediately produce the dramatic symptoms most people associate with heart disease. It compensates. The heart is extraordinarily good at compensating. It beats a little faster to maintain cardiac output when its efficiency drops. It enlarges slightly to maintain stroke volume when its muscle weakens. The kidneys retain a little more fluid when cardiac output falls, expanding blood volume to help maintain blood pressure. These compensatory mechanisms can sustain the appearance of relative normality for months or years while the underlying disease progresses. But compensation is not free. It has a cost, and the cost shows up not as chest pain in the early stages, but as subtle, easily explained shifts in how the body feels and functions. That is what the 5 signs are. They are the body's compensation mechanisms becoming visible. They are the cost of the heart working harder than it should to maintain the appearance of normality. And the reason they are so consistently missed is that each one of them, examined individually, has a simpler explanation immediately available. Together, they do not. Together, they are telling a single story. And that story requires someone to listen to all 5 at the same time. The first silent warning sign is persistent, unexplained fatigue, not the tiredness of a demanding week, not the fatigue that follows poor sleep or unusual exertion and resolves with rest. Fatigue that has been present for weeks or months. Fatigue that is disproportionate to the demands being made. Fatigue that is better in the morning and worse as the day progresses. Fatigue that makes activities that were previously effortless feel like they require deliberate effort. Here is why this is dismissed universally. Fatigue is the most common complaint in all of primary care medicine. It is attributed to aging, to stress, to low iron, to thyroid dysfunction, to depression, to poor sleep, to vitamin deficiency. All of those are legitimate investigations, and all of them should be explored. But the kidneys are not the first thing a GP investigates when an older adult presents with fatigue. And the heart is rarely the first either. Yet cardiac fatigue has a specific biological character that distinguishes it from every other type if the right question is asked. Here is what is actually happening inside the body. When the heart's pumping efficiency falls, when the ejection fraction drops, when the coronary vessels are narrowing and restricting blood flow to the myocardium itself, the volume of oxygenated blood delivered to the body's tissues per minute decreases. The muscles receive less fuel. The brain receives less oxygen. Every physical activity requires a greater percentage of the body's reduced cardiac output. The person experiences this as an effort that did not used to require effort, as a tiredness that arrives earlier in the day than it should, as a heaviness to the limbs that is not muscular soreness. This is not fatigue from overexertion. It is fatigue from undersupply. And no amount of sleep or rest corrects it, because the supply problem continues while the person rests. Research published in the European Journal of Heart Failure found that fatigue was the most commonly reported early symptom in patients subsequently diagnosed with heart failure, present in over 70% of cases, and that the average delay between its onset and formal cardiac investigation exceeded 14 months. 14 months of the most common early warning sign of heart failure being attributed to everything except the heart. The action is specific. If you have been experiencing persistent fatigue that does not resolve with adequate rest, that has been present for more than 6 weeks, and that you cannot attribute to a clear cause that has already been investigated and confirmed, ask your doctor specifically to include an echocardiogram and a BNP or NT-proBNP blood test in your investigation. BNP, brain natriuretic peptide, is a hormone released by the heart muscle under stress. Elevated BNP is a direct and sensitive marker of cardiac strain. It takes a single blood draw. It takes minutes, and it can identify a struggling heart before the echocardiogram has even been arranged. And the second sign catches people even more off guard because it involves something that everyone over 60 has experienced and almost everyone attributes to the same cause. The second silent warning sign is breathlessness that is disproportionate to the activity that produced it. Not breathlessness at rest. Not the dramatic shortness of breath that arrives without any physical cause and frightens the stuck person into calling an ambulance. The breathlessness of climbing 1 flight of stairs when 2 flights used to cause no problem, of walking to the end of the street and needing to pause, of carrying a bag of shopping from the car and feeling winded in a way that takes longer than it should to resolve. the breathlessness that has been creeping slowly toward activities that used to be effortless. Here's why this is dismissed. Deconditioning is the explanation that fits perfectly and requires nothing further. Everyone knows that if you have been less active, climbing stairs becomes harder. Everyone knows that fitness declines with age. The slope of that decline is so gradual and so universally expected that most people cannot identify the point at which normal age-related deconditioning became something that required medical investigation. That inability to identify the inflection point is exactly what the heart's compensatory mechanisms are designed to produce, and it is exactly what allows significant cardiac disease to progress undetected. But here's what is actually happening inside the body. Breathlessness with exertion in cardiac disease is produced by a specific mechanism that is fundamentally different from the breathlessness of deconditioning. When the left ventricle fails to pump efficiently, blood backs up. The left ventricle cannot move all the blood forward into the systemic circulation. The pressure rises in the left atrium behind it. That elevated pressure is transmitted backward into the pulmonary veins, the vessels bringing oxygenated blood from the lungs to the left side of the heart. As pulmonary venous pressure rises, fluid begins to leak from the pulmonary capillaries into the lung tissue. The lungs become stiffer. Gas exchange becomes less efficient. The act of breathing requires more muscular effort to move air through lungs that are beginning to fill with fluid. The person feels breathless because the lungs are working against increased resistance, not because the muscles are unfit, because the heart is not moving blood forward adequately and the consequence is backing up into the respiratory system. A study from the American Heart Association found that exertional breathlessness, specifically breathlessness that was new or worsening over a period of weeks to months, was present as an isolated symptom in 43% of patients subsequently diagnosed with new onset heart failure who had presented to primary care. 43%. More than 4 in 10, with breathlessness alone, attributed to deconditioning, to weight gain, to asthma, to anxiety, and eventually confirmed as cardiac failure on investigation. If your breathlessness with exertion has increased over the past 3 to 6 months, and particularly if it has progressed to activities that previously required no effort, please request a chest X-ray and an echocardiogram. The chest X-ray may show early pulmonary congestion, fluid accumulation in the lungs, that is the radiological signature of left ventricular dysfunction. The echo will show you the pumping function directly. Do not accept deconditioning as a complete explanation for breathlessness that has been getting worse. That explanation is only complete when cardiac causes have been excluded. But the next one is where things become far more serious. And it is a sign that surprises almost every patient I tell it to, not because the symptom is unfamiliar, and because the explanation they have been given for it is one of the most convincingly wrong attributions in all of clinical medicine. The third silent warning sign is nocturnal discomfort in the chest, jaw, upper back, or arm that has been attributed to indigestion. Specifically, discomfort, not necessarily pain, that wakes the person from sleep or occurs in the hours after a large evening meal that responds partially to antacids, and that the person has been managing as a gastrointestinal complaint for months without formal investigation of the heart. This is where people get dangerously confused, and it costs lives with a regularity that I find genuinely distressing. Here is why the confusion happens. The heart and the upper gastrointestinal tract share many of the same pain pathways through the autonomic nervous system. Cardiac ischemia, while reduced blood flow to the heart muscle, produces sensations that are transmitted through the same nerve fibers as esophageal spasm, gastric distension, and acid reflux. The brain cannot reliably distinguish between them at the level of conscious experience. The person feels something in the chest, they have a history of heartburn, they take an antacid. The antacid helps somewhat because it reduces esophageal irritation that may coexist with the cardiac ischemia or simply because the ischemic episode is transient and would have resolved regardless, they conclude it was indigestion, and the cardiac ischemia that produced or contributed to the discomfort is never identified. Here is what is actually happening inside the body. Cardiac ischemia occurs when the demand placed on the heart muscle exceeds the blood supply the coronary arteries can provide. In a healthy coronary system, the arteries dilate to increase blood flow when demand rises. In a coronary system narrowed by atherosclerotic plaque, the dilation capacity is limited when demand exceeds what the narrowed arteries can supply. The myocardium, the heart muscle, becomes temporarily oxygen deprived. Ischemic cells release chemical signals, adenosine, bradykinin, substance P, that are detected by the cardiac afferent nerves and transmitted to the spinal cord. Those signals are interpreted by the brain as discomfort in the chest, jaw, left arm, upper back, or epigastrium. The upper abdomen, in the supine position, lying flat at night. Venous return to the heart increases. Cardiac workload increases. And ischemic episodes that did not occur during the day can occur during sleep. The person wakes, they feel discomfort, they take antacids, they go back to sleep, and the ischemia that caused the waking has not been identified, has not been treated, and will recur. Research from the British Heart Foundation confirmed that misattribution of cardiac ischemic symptoms to gastrointestinal causes was responsible for a significant proportion of delayed myocardial infarction presentations in adults over 60%. That women were significantly more likely than men to experience atypical ischemic presentations involving jaw, back, and epigastric discomfort rather than classic central chest pain. The classic presentation is not the only presentation, and treating the atypical presentation as a gastrointestinal complaint while the ischemia continues is one of the most dangerous diagnostic errors in clinical medicine. Let me ask you something. Have you been waking at night with discomfort in your chest, jaw, upper back, or upper abdomen that you've been attributing to what you ate? Is that discomfort new in the past 6 to 12 months? Have you been managing it with antacids without formal cardiac investigation? Tell me in the comments below, because the number of people watching this video who are doing exactly that is far larger. That's cost. It should be. And the cardiac investigation that would either confirm or exclude ischemia as the cause takes one morning and a resting ECG and possibly a stress test. That investigation is the difference between managing the right problem and managing the wrong one while the right one progresses. The fourth silent warning sign is swelling in the ankles, feet, or lower legs that is consistently present at the end of the day and does not fully resolve overnight. Not the swelling that comes and goes with heat or long periods of standing. Persistent, bilateral. Both legs equally present most evenings, slightly better in the morning but not gone. Here is why this is dismissed. Leg swelling in older adults has a long list of explanations that are all more familiar than the heart. Standing too long. The heat. Varicose veins. Arthritis. Kidney function. Medication side effects. All of those are real and common causes of peripheral edema in this age group, and because they are real and common, the heart is often not the first investigation pursued. But here is what makes cardiac edema specifically identifiable from the rest of those causes. If the right questions are asked at the right time, here is what is actually happening inside the body. When the right ventricle of the heart fails to pump with adequate force, a condition called right heart failure that frequently accompanies or follows left ventricular dysfunction, the venous system backing up on the right side of the heart becomes congested. Venous pressure in the peripheral circulation rises. Fluid is pushed out of the capillary beds and into the surrounding tissue. Gravity pulls that fluid to the lowest points of the body, the ankles, the feet, the lower legs. The fluid accumulates throughout the day and is partially reabsorbed overnight when the legs are elevated during sleep. By morning, it is better. By evening, it is back. This cycle, better in the morning, worse in the evening, consistent from day to day, is the pattern of cardiac edema. And it is the pattern that distinguishes it from the random, weather-dependent positional swelling of most other causes. Additionally, and this is the detail that most people miss entirely, when the kidneys detect a fall in cardiac output, they respond by retaining sodium and water. This is a compensatory mechanism designed to increase blood volume and therefore cardiac filling pressure. But in a failing heart, this compensation produces fluid overload rather than improved function. The retained sodium and water accumulate in the peripheral tissues. The swelling is not just gravity. It is the kidneys compensating for the heart by holding on to fluid that has nowhere useful to go. Research published in the Journal of the American College of Cardiology found that bilateral ankle edema was present in over 60% of patients diagnosed with new-onset heart failure presenting to emergency departments, and that in the majority of those cases, the edema had been present for at least 8 weeks before the cardiac diagnosis was made. 8 weeks of bilateral ankle swelling that had been attributed to other causes while the heart failure progressed undetected. If your ankle or leg swelling is bilateral, consistent from day to day, better in the morning and worse in the evening, and has been present for more than 4 weeks without a clearly identified and confirmed non-cardiac cause, please request a BNP blood test and an echocardiogram at your next appointment. And if you are currently on a medication that causes edema as a side effect, such as amlodipine or other calcium channel blockers, ask your doctor to confirm that medication side effect rather than simply assuming it. A BNP level will help distinguish medication-related fluid retention from cardiac decompensation even in that context. The fifth silent warning sign is the one I wish more people were warned about years earlier. It is the most overlooked. It has the most variable presentation, and it sits quietly in the recent histories of more cardiac patients than most people would believe until they have heard it described. Precisely, it is palpitations. But not the palpitations most people imagine. Not a racing heart that arrives dramatically and sends them to urgent care, the subtle kind. An occasional awareness of the heartbeat that was not there before, a brief sensation that the heart skipped or added a beat. A moment of feeling the heart in the chest in a way that is simply noticeable, not frightening, not prolonged, just present in a way. It not useful, occurring once every few days, lasting seconds, resolving completely, attributed to caffeine, to stress, to lying in a certain position, to getting older. Here is why this specific presentation is the most dangerous of the 5. Because it is the most likely to represent a cardiac arrhythmia that is itself a consequence of structural heart disease. And because cardiac arrhythmias in the context of structural disease carry risks that arrhythmias in otherwise healthy hearts do not. When the myocardium is under ischemic stress, when the ventricular muscle is enlarged or weakened, when the conduction system of the heart is being disrupted by fibrosis or ischemia, the electrical environment of the heart becomes unstable. Ectopic beats, premature contractions originating outside the normal pacemaker become more frequent. Short runs of ventricular tachycardia can occur. Atrial fibrillation can begin in paroxysmal episodes that are brief, self-terminating, and easily explained as a fluttering or a funny turn. These electrical disturbances are not innocent in the context of a heart that is already under structural stress. They are the heart's electrical system reflecting the mechanical problem beneath it. Here is what is actually happening inside the body. Ischemic myocardium heart muscle that is receiving inadequate blood flow becomes electrically unstable. The normal ion channels that govern the orderly propagation of electrical signals through the heart muscle are disrupted by hypoxia. The electrical threshold for abnormal beat generation falls. Ectopic foci, areas of cardiac tissue that begin generating their own electrical impulses outside the normal rhythm, become active. The person feels those abnormal beats as a brief thump, a flutter, a skip, a missed beat. They feel them intermittently because the ischemia itself is intermittent. Worse with exertion or at night when demand. exceeds supply in the narrowed coronary vessels, and they dismiss them because they are brief, because they resolve, and because they have a ready explanation in caffeine or stress that allows the mind to move on. Research from the European Heart Journal found that new onset palpitations in adults over 60, specifically palpitations that were new, that occurred more than once a week, and that could not be attributed to a clear and confirmed cause, were associated with the significantly elevated rate of underlying structural cardiac disease on subsequent investigation compared to younger adults reporting similar symptoms. The age was the variable. The same symptom carries a different clinical weight in an older adult, and it deserves a different level of investigation. If you're experiencing new palpitations, even brief, even mild, even easily explained, request an ECG at your next appointment. Then, if the resting ECG is normal but the episodes are continuing, ask specifically for a 24-hour or 48-hour Holter monitor. A Holter monitor captures your heart's electrical activity continuously during your normal daily life. An episode of ectopy, atrial fibrillation, or ventricular arrhythmia that occurs during the monitoring period will be captured and reviewed by a cardiologist. That recording changes everything about how the subsequent investigation proceeds. And for a person whose palpitations are being driven by structural heart disease, the recording is the beginning of the pathway that leads to appropriate management before the event that a cardiac arrhythmia in a diseased heart can trigger. Let me bring all 5 together now, because I want you to understand them not as a list, but as a conversation. A conversation your heart has been trying to have. Persistent fatigue disproportionate to activity. The pump is delivering less than the body requires, and the body is compensating through effort. Breathlessness with activities that previously required no effort. Fluid is beginning to back up into the lungs because the left ventricle is not moving blood forward efficiently. Nocturnal chest, jaw, back, or upper abdominal discomfort attributed to indigestion. The coronary arteries are narrowed, and the ischemia is occurring when the body is horizontal and cardiac demand rises. Bilateral ankle and leg swelling that is worse in the evening and better in the morning. The right ventricle is failing, and the kidneys are retaining fluid in compensation. And new palpitations, brief, intermittent, easily explained. The electrical system of the heart is reflecting structural disease in the tissue beneath it. 5 signs. All of them mild individually, all of them explainable as something else, all of them together. The language of a heart that has been sending the same message through 5 different channels for months. The message is not subtle. The message is urgent. What has been subtle is our ability to receive it when each channel is examined only in isolation. Knowledge without action is just worry, and I am not here to make you anxious. I am here to give you a plan. I call this the Silent Warning Response Protocol. 5 steps, beginning this week. Step 1. Write down every one of the 5 signs you have been experiencing. Be honest. Not the ones that frightened you, all of them. The fatigue you attributed to getting older. The breathlessness you attributed to being less active. The indigestion that has been waking you. The ankle swelling you have been ignoring. The occasional awareness of your heartbeat you explained as caffeine. Write them all down with how long they have been present. That written list is a clinical document. Bring it to your next appointment. Step 2. Request a resting ECG at your next GP appointment. A 12-lead electrocardiogram takes 5 minutes. It is painless. It is available in virtually every GP practice. It will identify existing arrhythmias, signs of previous ischemic damage, and electrical abnormalities that indicate structural heart disease. It will not show everything, but it will show something, and something is where the investigation begins. Step 3. Request a BNP or NT-proBNP blood test. This single blood test measures a hormone released by cardiac muscle under stress. An elevated result in the context of the symptoms I have described is a powerful indicator that the heart is the source of those symptoms and that urgent cardiology referral is warranted. It requires 1 blood draw. It provides information that cannot be obtained any other way without imaging. Step 4. Request an echocardiogram if the BNP is elevated or if your symptoms are present and your GP has clinical concern. An echo is the direct view of the heart's structure and function. It shows the ejection fraction, the percentage of blood pumped out with each beat. It shows the size and wall motion of the ventricles. It shows the valves. It shows the pericardium. It is the investigation that transforms a collection of unexplained symptoms into a specific cardiac diagnosis. And it is available in most cardiology centers without requiring hospital admission. Step 5. If you're already under cardiological care, if you already have a heart condition being managed, bring the 5 signs I have described today to your next cardiology appointment and ask specifically whether each of them has been accounted for in your current management plan. Stable cardiac disease can become unstable. Compensated heart failure can decompensate. The signs of that transition look exactly like the 5 things I have described. They deserve explicit attention in every cardiology review, not just the blood pressure and the medication list. The symptoms, the daily experience of the person living with the condition. I want to come back to Vincent. After his echocardiogram and his angiogram, Vincent underwent coronary artery bypass grafting. 2 vessels. He recovered well. He was started on an appropriate heart failure medication regimen, and his ejection fraction, measured 6 months after surgery, had improved to 51%. He attended cardiac rehabilitation. He walked properly, with monitoring, with progression, for the first time in 2 years, without stopping to catch his breath. He came back to see me 8 months after his surgery with his wife. She looked as though she had slept properly for the first time in 2 years. He sat down across from me and he put both hands flat on the desk and looked at them for a moment. Before he spoke, he said, "I kept telling myself it was age. I kept saying that to her and she kept saying it wasn't." He looked at his wife, and then he looked back at me and said, "The words I have heard in this work more times than I can count but never stop hearing." He said, "Why didn't I go sooner? What was I waiting for?" That question has stayed with me ever since. It is a significant part of why I make these videos. Let me say each sign one final time. Persistent fatigue that rest does not resolve. Breathlessness with activities that previously required no effort. Nocturnal chest or upper abdominal discomfort attributed to indigestion. Bilateral ankle swelling, worse in the evening and better in the morning. New intermittent palpitations, dismissed as caffeine or stress. 5 signs. 1 message. The heart is telling you something, and now you know how to hear it. Which of these 5 signs do you recognize in yourself or someone you care about today? How long have you been explaining it away? Tell me in the comments. I read every single one, and those answers help me understand how many people are living with a conversation from their heart that nobody has yet translated for them. If this video gave you something that changes what you do at your next appointment, share it. Not for me, for the person in your life who has been tired for a year and calling it age, who has been taking antacids for nocturnal discomfort that has never been properly investigated, who has swollen ankles every evening and has never had a BNP level checked. They may not know what their body is trying to say, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. Please do not use this information to self-diagnose or to delay seeking emergency care if you are experiencing symptoms that may represent an acute cardiac event. If you have chest pain, severe breathlessness, or symptoms that feel urgent right now, stop watching and call emergency services immediately. For everything else, the subtle, the gradual, the easy to explain away, bring what you have learned today to your own physician. They know your history. I do not. This is education. Use it as the beginning of that conversation. The conversation Vincent wishes he had started 8 months earlier.